As part of the School of Advanced Study in the University of London, the Institute is committed to a spirit of interdisciplinary inquiry focused on the humanities as a means of better understanding the world we face. Today's workshop is entitled Life, Death, and Health During the Pandemic and features 3 papers. Our format is as follows. Each speaker will have up to 20 minutes to present their paper, and questions can be raised by our audience members in the Q&A function at any time. Following each speaker's presentation, I will attempt to moderate questions to that presenter and also to raise your general questions and comments at the end of the session. The workshops are scheduled for 90 minutes. Our first speaker today is Dr. Huiyun Chan. Huiyun is Senior Lecturer at the Law School of the University of Huddersfield. Her research interests lies within the area of health law and bioethics, with particular interest in end-of-life care, care ethics, and medical humanities. She recently published a monograph, Advanced Directives, Rethinking Regulation, Autonomy, and Healthcare Decision-Making. Huiyun's paper is entitled Death, Burials, and Funerals, Grieving in the Shadow of COVID-19. Welcome, Huiyun. Over to you.
Thank you, Carl, for the introduction and the invitation to participate in the series. And hello to my fellow speakers and the audience. Thank you very much for joining me in today's webinar. I'm looking forward to share my work in progress on one of the issues raised in the current climate, and the topic is death, burial, funerals, and grieving during the pandemic. So here we can see examples of COVID deaths charted across the world, and the increase in burials undertaken at the height of the pandemic. For example, on the bottom left photo, we can see mass burials in Brazil, and on the bottom right in New York City. These developments have created additional pressures in burials and funeral arrangements. Burials were expedited, and the sudden loss of loved ones has left living relatives traumatized. They have to cope with the administrative arrangements for the dead, while struggling with the loss and the grief as they navigate funerals in a very different atmosphere compared to conventional times. With this in mind, I will start with an overview of the common practices and distinct rituals relating to burials, funerals, and their importance. We can see how these practices are closely linked to grief. At the height of the pandemic, particularly between April and June, restrictions were imposed on the conduct of burials, funerals, and participation in funeral services. The focus of the discussion is how the pandemic has affected these practices. In particular, I will highlight how the restrictions balance the need to protect public health and allow individuals to honor the deceased. I will also consider the long-term implications to bereaved families from the inability to have closure and the physical and mental anguish at being deprived of the opportunity to grieve properly. I will then conclude with some reflections on potential options to support bereaved families. The practice of burying the dead and rituals associated with it have been immortalized since ancient times. Burial is the practice of burying a dead body, while a funeral is the ceremony held after a person's death that provides the opportunity for living relatives to honor the dead and for families and friends to gather to offer and share social and emotional support. A typical funeral process begins with the pronouncement of death, care of the deceased, awake to the day of the funeral, the service, and burial. Once death is notified, families, usually in conjunction with funeral directors, will decide on burial, cremation, or embalming, and how to dress the deceased. In ordinary times, death notices, coffins, flowers, and funeral service orders are carried out. Where death happens in hospitals, medical staff will be responsible for preparing the body for funeral and storing in refrigerated units while awaiting funerals. The bereavement services officer will arrange for the transport and disposal of bodies in cooperation with local authorities. The time between deaths occurring and funeral taking place normally lasts from 5 to 10 days and sometimes longer. There are some traditions of viewing the body and holding a wake prior to funerals, where relatives visit the bereaved families with offerings of meals or refreshments. On the day of the funeral, relatives and friends will congregate in churches, graveyards, or crematorium. Where services are held indoors, there will usually be music and singing with eulogies and speeches by close family or friends. Following funeral services, burials take place with further words or prayers at the graveside as the coffin is lowered into the ground and filled. We can see that they are often represented by the coming together and very much communal nature of honoring the dead person and to remember their legacy. So burial and funeral practices are significant. They represent a respect for the dead and a collective sympathy to the loss of loved ones. These are often expressed as therapeutic for the bereaved. Funerals fulfill critical psychological and social needs. They are essential in helping individuals navigate grief. It's a rite of passage because their passing must be recognized. Surviving families must be supported and they must be reintegrated into the community. Rituals are important in funerals. They assist in acknowledging and expressing feelings and stimulate the recollection of the deceased. A ritual allows the community to provide social support to the bereaved and a meaningful structured activity to counter the loss. Rituals also give new meaning to the bereaved in realizing how the death has affected themselves and their religious framework. Rituals in funerals and burials are often associated with ancestral spirits and safeguarding cultural values. That is why the living needs to grieve and spend time with the deceased. The spiritual connections between them are often translated to actions in reminiscing the deceased, memorializations, open casket viewing, or speaking to and touching the deceased softly. So these actions are significant in facilitating closure. So the rituals of touching, bathing, and dressing the body and spending the final moments represent the act of caring, and they are considered valuable to the bereaved. Religious and cultural traditions in rituals provide structures to remember the deceased, where non-observance may result in anguish or family disagreements. For example, Catholics perceive the opportunity for a priest to hear the final confession of the dying as essential. Another example is the African Caribbean Christians in England. They have strong familial influences and community practices. So family and community participations are significant. Funerals are elaborate with live music and singing and further gathering at the family home. There is some similarity with Irish wakes, which are lively, filled with storytelling, card games, songs, and dance. The rituals also serve as a national identity. For example, in migrant communities, customs are performed following those of the homeland for the benefit of the younger generation. Some cultural customs have lamentations as part of their grieving process, which would not have been possible due to the restrictions. We can see that these rituals offer the opportunity for the living to reflect on life while grieving. They indicate the transition of the deceased to what is hoped as a peaceful afterlife. Emotional support is very much valued. The beginning of coronavirus marked a stark contrast to the traditional burials and funerals. The increase in death created pressure points in the funeral process, leading to mass rapid burials and dispensation with strict religious burial requirements. So for example, the photo on the top right, They show refrigeration trucks, which are being used to store the bodies while awaiting burials. Healthcare workers and those in the mortuary are all dressed in personal protective equipment, PPE. Bodies are wrapped and transported quickly in body bags, wiped down with disinfectants. Funeral directors are also advised to wear PPE. So the photo on the top left showed a scene from Iran in transporting the body, and the photo next to it showed the burial preparations in Spain. We can see the heightened precautions to the workers and families. The key principle is the protection of health and the prevention of transmission risks arising from reinfection as a result of handling the body. So individuals and families experience disruptions to familiar burials, funerals, and their grieving process. For example, a Jewish family experienced an online funeral via Zoom for almost 2 hours instead of the traditional 7 days. Different states in the US, Indonesia, Bangladesh, France, and Italy impose immediate prohibitions on the ritual of washing the deceased, viewing the body, and large gathering of funerals and burials. These have caused isolated funerals, simplified rituals, shortened funerals, and a significantly shortened time period in claiming dead bodies on public health grounds in reducing reinfection risks. In England, the Coronavirus Act, which came into force, has also changed the way people bury and grieve for the loss of loved ones. Under the legislation, national and local authorities are granted specific powers in relation to transportation, storage, and disposal of dead bodies. These powers enable local authorities to direct funeral and crematory directors to simplify the death management process. A potential consequence is the possibility that disposal choices may be disregarded. So this has caused concern among religious groups with specific requirements regarding the risk of enforced cremation against their religious prescriptions. So the government in response has reassured the groups that the power granted, if exercised, must have regard to the desirability of disposing the bodies in accordance with the person's wishes or religious beliefs. So the local authorities are directed to work with local communities in agreeing on the appropriate modes of disposal that accommodate the person's wishes as far as possible. Now, specific restrictions also apply for the care of the deceased with suspected or confirmed COVID-19. Family members are advised to withhold touching the bodies, to maintain 2 meters distance, and to call for help from healthcare professionals. This means that only trained professionals are allowed to wash the bodies, while bereaved families are strongly advised not to participate in these rituals. Where contact is considered necessary, they are advised to wear PPE with oversight by trained professionals. While funerals are permitted to continue, restrictions are underpinned by public health protection to curb transmission risks. So the expectation is that funerals are to be expedited. They are socially and physically distanced, where only the closest family members are allowed to attend. So this is in contrast to customary funerals, where relatives and friends are able to be physically present and to offer support to the bereaved. Unlike the current permission, which allows up to 30 people to attend a funeral, the provision in force in April permitted only the members of the person's household and close family members to attend, in addition to the funeral director, chapel attendant, and funeral staff. Where family members are unable to attend, their close friends may attend. So we can see that it emphasized the heightened transmission risk as a result of intermingling between different households when families and friends travel across the country to attend funerals. The restrictions extend to traveling to and from funerals, where they are directed to face away from each other. While the law aims to balance the caution to protect public health and meet the needs of bereaved families to perform the last rites, the social distancing requirements and public health safety meant that any rituals that are performed are considered to be incomplete and so may not likely temper the gravity of the grief and the need for consolation. For example, families where they are permitted to conduct simplified rituals in very limited circumstances had to wear PPE and supervised by trained professionals. So this gave the appearance of being further detached from the disease, which would amplify their loss and the sorrow. Similarly, they are unable to spend the final moments with the deceased privately, which could also add to the pain felt. So these developments could result in deepened grief for the bereft because specific rituals represent the transition towards accepting that death has occurred and letting go in the grieving process. While digital streaming of funerals can provide some relief for the bereft, they do not fully alleviate the pain of loss and being present physically. So the advice for speedy burials and highly simplified funerals demonstrate that population health is given more priority, and the bereft are expected to understand and accept the modified approach despite being rushed through the process. So how does the living deal with the sorrow? Grief is a distinct personal reaction to the loss of any object to which an individual is attached. Grief lasts, unlike the assumption that time heals. There are long-term implications to the bereft families when they experience disrupted grieving. The dispensations with conventional rituals in burials and funeral services, restrictions in the number of in-person attendance, and the curtailed interactions have affected bereft individuals on a personal and emotional level. So this created anger, disappointment, deep frustrations, isolation, grief, and a sense of incompleteness. So a particularly significant implication is coping with being deprived of collectively sharing the grief. So physical expressions of support and comfort, such as hugs, sharing of tissues, are replaced with eye expressions of understanding due to physical distancing. The inability to participate because of self-isolation also can deepen the grief. Those who participated in funeral services remotely had to cope with interrupted live streaming. So all this could lead to complicated grief. So complicated grief is magnified grief, which resulted in deep anguish. So people experience a period of prolonged sorrow, continuous depressive moods, stress disorder, which are compounded by enforced physical distancing. So complicated grief, if unattended, could result in grave mental illness. So what can be done to support families who are bereft as a result of losing their loved ones? So bereavement support is essential. Now, protecting public health is broad enough to include supporting bereft families who experience complicated grief as a result of losing their family during the pandemic. So public health restrictions affecting burials and funerals should involve consultations with the communities so that they can appreciate and accept the implications. For example, emphasizing the importance of conducting identification in a safe and humane way can inculcate trust in public health authorities. This could be followed by regular bereavement support that accommodates specific religious and spiritual needs. So better coordination amongst bereavement bodies supported by strong leadership can also minimize the possibility of complicated grief. Organizing events to mark the loss due to pandemic could also be valuable in acknowledging the grief. So the continuity of support is crucial to support bereaved families to adjust to the loss and helping them transition from grief to hope. Thank you very much for listening, and I welcome your feedback and comments.
And thank you very much, Huiyan. The Q&A function is open for questions. If I could begin by, first of all, thank you for a really fascinating paper. You touch on the role of culture, cultural specificity, and the duty on local authorities to work with local communities. To what extent has the whole this area revealed really the challenges in a multicultural society in order to protect public health, but try to respect cultural difference and cultural specificity?
Thanks, Carl, for the question. It's very important, particularly in quite a diverse population, as is England, for example. And before, when the Coronavirus Act was passed, and a slew of guidance relating to the care and funeral and burial restrictions were in place, there was quite an uproar from specific religious groups. So particularly coming from the Jewish populations and also from the Muslims. And this is because there is a worry that there could be an enforced cremation, which is against the religious prescription. On the other hand, there's also the need to ensure that burials are conducted within 24 hours. And so during there was a consultation that was undertaken, and these concerns were voiced. And so the government's assurance was that they had to balance the need to protect public health, and also on the grounds that to prevent any transmission risk as a result of the delay from burial and speedy funeral. And so because of this, they have reassured the groups that these accommodations will be allowed as far as possible. And they encourage very much consultations and cooperation between the local authorities and also the public health authorities. So to work collaboratively to ensure that any restrictions will not be too onerous on the part of public health workers as well as on the family members. So usually conversations will take place in this aspect, and the ultimate aim is to ensure that families are not being treated disrespectfully, and as well as, and this extends also to the deceased family members, but they very much emphasize the need to ensure that there is no risk for reinfection as a result of handling the body and exposing other people to this risk.
Mm-hmm. Thank you. And just to turn the question around a bit as well, I think one of the concerning things we've seen in a number of countries has been the way in which some communities have been subject to a certain amount of blame for transmission, for failure to follow the rules. And this also extends to rituals of death and grieving. I mean, is that something that your impression is, does your research confirm that impression of mine, that the whole area of death can also result in communities, minority communities, being blamed for a failure to follow rules that have been set down?
Thanks, Carl. That's a very insightful question. Now, at the beginning of the coronavirus, so a small number of research has been undertaken in order to measure the kind of impact of these restrictions on the families. And so, unfortunately, there are reports about certain communities with particular rituals that are being sort of blamed in a way, unfortunately. And so, the one thing that I can try to understand is that this could result due to a lack of clear and proper communication between the people who are in charge of conducting and organizing the transportation and the coordination between the groups. Because this could also be because there are some the guidance came quite quickly, and so the local authorities would then need to consider how to implement, what are the best ways to implement this guidance in the best possible way, while also at the same time having to deal with a huge increase in burial and funeral arrangements. So this has actually caused quite a lot of backlog in the sense, and which could have also resulted in misunderstanding and lack of communication between the different groups. So, so far, there are no empirical research to date in investigating this particular aspect, but I think it will be something that I would certainly look further in understanding this aspect.
Thank you. And what also I thought was a fascinating aspect of your paper is your description of kind of new rituals that are emerging by necessity in the pandemic. And of course, rituals are cultural constructs that get reconstructed. Mm. Do you think we'll see a kind of will some of these new rituals, new forms of grieving outlast the pandemic and have a kind of lasting influence on the way we manage death?
I think certainly yes, because when the restrictions on in-person attendance was implemented, it has resulted in a surge in online funerals and also streaming of these services, so that there will be more people who can participate, which would also allow for families or friends who are living abroad to participate in these services. So in a sense, I think that it would certainly, it has actually popularized this sort of online streaming services, and then with these services being recorded for perhaps post-pandemic memorialization services or activities. And possibly, I think for a foreseeable future, it could definitely have an impact on how people grieve during this time. And so that there is certainly a surge in online streaming of these services, so that more people can join. And I would think that it would certainly continue, although people would ideally still prefer to attend in person if they could. But this would actually allow them an option to participate as well, although it would not be the most ideal way. But it is something which could also offer comfort and of value to the families who are grieving.
Well, Hui-Yin, thank you very much for your paper. Fascinating. And we look forward to its inclusion in our outputs from the series. So thank you very much.
Thank you.
We move now to our next speaker, Dr. Sabrina Germain. Sabrina is a senior lecturer at the City Law School, City University of London. Her research interests lie in the connections between public and private entities in healthcare law. She's most interested in the role of the medical profession in the elaboration of healthcare reforms and questions of resource allocation for the British, Canadian, and American healthcare systems. Her recent monograph is entitled Justice and Profit in Healthcare Law. Sabrina's paper concerns the politics of COVID-19, reshaping healthcare law and policy in the UK. And welcome to you, Sabrina.
Thank you very much, Carl. Thank you for the nice introduction, and thank you for the invitation. And thank you also to Dali for helping us with this event. I will start by sharing my screen now. Hopefully you can all see my presentation now. Very good. So it's a real pleasure to be speaking today. As you may see, notice that I've changed slightly the title of my presentation to the role of medical professional in shaping healthcare law during COVID-19. This is a paper that's part of a broader project that I lead with the Center for Healthcare Innovation Research at City University, and I'll speak a little bit more on that in conclusion or during the question time if there's interest. So what was so scary about the first peak of infection in England? Well, of course, this is a new virus. This is something really unknown. But when I sat down with my colleague in the center, we were wondering really whether it was about not having enough loo rolls, not having enough time to share with our loved ones, and really not having enough ventilators, unfortunately, potentially for the healthcare system. And maybe I'm alone on this, but I would think that there's a shared understanding that the need for ventilators kind of superseded the need for loo rolls for most of us in England, at least. And this may be because of the nature of healthcare resources. They are not unique or special per se, because we know that nutrition and environment certainly contribute to good health, but they sit at a particular place in our societies that's pretty crucial, because they are able to alleviate suffering and in some instances push away death. So really in England, at least with the NHS, we do believe that healthcare is a question of justice. So what does that mean exactly in healthcare policy? Well, we have 4 different models of distributive justice. Some of you may be familiar with them. Liberal equality, egalitarianism, posits that we should be all put on equal footing, because at birth we are not equal with the lottery of life. Unfortunately, some people have a more allotment of good health than others, but we should have equal footing, provide more resources to the least favors to reestablish this equity, or provide equal access at least to all healthcare services for all. And this is kind of the utopia on which the NHS was founded and kind of the bedrock of our system. The utilitarianism perspective is different. It believes that since we have scarce resources, we should be allocating them in priority to different sets of patients. So there's different ways of ranking, sometimes according to need, sometimes according to health outcomes. For instance, if you are more likely to survive after being put on the ventilator, well, perhaps we will allocate the ventilator to you. And that was one of the policy lines. So that's the maximization of scarce resources. Communitarianism is particular as it defines itself as a collection of thoughts of different authors in opposition to egalitarianism, and believes that the collectivity should be setting the rules for the allocation. And the collectivity can be as small as the family unit or as big as the nation. We've seen a little bit of communitarian approach in the lockdown rules when we were told, well, let's all stay at home. It's not about you, it's not about me, but it's all about us all together trying to flatten that curve. Libertarianism is a perspective that's very much cherished by our American friends, where they do believe that the market should allocate those scarce resources. They're part of a property entitlement and not a human right per se. Neoliberalism goes even further, saying that we should decentralize healthcare services and privatize them. So overall, you see, if we have good models, or at least one model to allocate resources, we most probably will have consistency, we hope, in the application of that model, and therefore that will lead to a bit more transparency and then procedural justice. So distributive justice, hopefully leading to some procedural justice. So what happened in the UK, or in England more precisely, during the first peak of infection? Was there justice? Were medical professionals involved? These were the sort of questions that I had for myself back in March 2020. COVID was declared an outbreak of a monumental moment of national emergency by Boris Johnson. We needed to protect the NHS, stay at home and save lives. And also we needed to implement a series of measures: disruption in routine care, prioritization of COVID-19 infected patients, and low rate of admissions in A&E resulted for multiple reasons. But this is quite interesting to know whether or not healthcare professionals, apart from the public health officials that we were seeing on TV, did they really have a say in this or not? Why am I so interested in what they have to say? Because I've been interested, as Carl mentioned in the past, of what they had to say about other healthcare reforms. I'm mostly interested in rhetoric of justice in healthcare law and the role of those key actors, medical professional, in the lawmaking process. So why discourse, written or oral? Well, because it is a form of social practice, and that communication informs us of the speaker or the author's identity and reveals factors that contribute to social change. Rhetoric in the public discourse is often used to convey the desires of the author, but also the deep lying objective of a rule that may not be reflected in the final legislative outcome. So in non-pandemic time, I've been interested in particular sets of document, policy document mainly, and legislative documents, because the government allocates resources, of course, setting broad policy objectives, but also can do an overturn or change the allocation through a healthcare reform and NHS Act. That comes up first by a policy proposal with a white paper, which I analyzed, and then by the introduction of a bill through Parliament. And I focus mainly on the second reading of those laws and this transcript of those debates, as they really tells us about the deep meaning of the law. In pandemic times, things are very different because there's emergency. We have to operate at breakneck speed. We didn't have time for a legislative process in March, April 2020, but we know, looking at some of the document that's available, it's not very transparent, but NICE has amended its own manual for drafting guidelines and said that they would be drafting the guidance for COVID-19 in a very speedy manner, involving some of the stakeholders from patients group, medical professional and ethicists, but they would be running the process simultaneously instead of in sequence like they usually do. So we would assume that other groups that are involved in guidance would follow a similar path. So my findings from the monograph that I published are that mainly in healthcare reforms, there is a defined role for medical professionals. In the 1950s, they kind of entered this tacit concordat with the state, what we call the double bed relationship, which made them very much the promoters of the libertarian and egalitarian, the liberal egalitarian rhetoric, focus on universality of care, equal access to healthcare, but also very protective of their personal autonomy. In the 1980s, when we had to rationalize and the Thatcher government was more stern with regards to their involvement, well, they erected themselves in opposition to the government and wanted to, again, push their egalitarian rhetoric against the utilitarian and libertarian rhetoric of the government. In the 1990s, the New Labour has a more collaborative approach, but the medical profession continues to be protective of universality of care, even though the government pushes for a consumerist approach. The 2000 really brings in a period of turmoil between the government and medical professionals in healthcare policy and lawmaking. We see a healthcare professional directly in opposition to the government. It created an uproar, the 2012 healthcare reform, because of the introduction of the independent sector in the provision of services. There, it is clear the rhetoric is highly egalitarian on the medical professional side because they're trying to save the NHS. And by this, they mean save universal access to healthcare services. So I would say that the traditional role of healthcare professionals is the defenders of egalitarian value, or at least the rhetoric, and professional autonomy. Emergency guidance, as I said, are different. They don't operate in the same kind of spectrum because we're dealing with crisis and we're dealing with emergency. But what are the sources? Well, we had 4 different sources of guidance, or so far, and now we will see what happens in the second peak of infection. But NHS England was quick to put out some specialty guidance that is very technical and rather geared towards practitioners, what to do in a situation of clinical emergency, which chest x-ray to operate, how to intubate a patient, etc. They don't really provide a lot of information on a broad principle of ethics for distribution of resources. NICE published some very controversial guidance in March 2020 that was threatened to be subject to judicial review because of its discriminatory nature. Again, went backwards on and edited the guidance, but doesn't provide, except for that one, a lot of information on resource allocation. However, the British Medical Association, which is the union of medical professionals, provides us with a very interesting 10-page document on ethical principles on how to allocate resources and operate triage. Among other things, of course. And it deals with patient management, personal protective equipment, and the allocation of healthcare resources and triage, as I said, and the management of human resources. So it's a very interesting document that I will be presenting to you. The Royal College of Medicine and the Royal College of Physicians particularly also offers some guidance that is a shorter document and that is a kind of broad stroke on ethics and allocation of resources. So the BME guidance was published roughly a week after we entered our first lockdown in England and a few days after the World Health Organization declared COVID-19 as a global pandemic. The purpose was to address the ethical challenges and provide some clarity to practitioners concerning their ability to provide safe care, and also to help them know whether or not they would be subject to litigation after having provided treatment in these circumstances. Although it's not explicitly stated, we do know that they were supported by royal colleges, as some of them have the guidance up on their pages. And there was a series of communication around the guidance itself on the BMA website, which I have also analyzed. And it was press releases and blog posts, and they focused mainly on personal protective equipment and the lack of resources. And we will see why that may be. So the guidance opens, of course, on the very unusual circumstances and dramatic circumstances of the outbreak, but also starts by stating the framework that underpins the guidance, which is the pandemic flu framework that was initially published in 2009, and that was edited again and revised in 2017. These are only a few of the values from the framework. I couldn't reproduce all of them. But what's interesting is not only that there's a clear egalitarian underpinning and a worry and a really an attention that is given to procedural justice, but also the fact that medical professionals decided to publish an old or support themselves from a previous published framework. Again, we see that the medical profession didn't use this opportunity as an opportunity to set their policy foot forward, if I can speak like that. Then maybe because, of course, they were dealing with a ranging crisis, and they were also carrying out their clinical roles while drafting the guidance. So it was a lot to deal with, and they also maybe perhaps wanted a sense of certainty, having something that was already in place. So the guidance is very interesting, as it kind of goes, it balances between two main rhetorics. Of course, utilitarianism is present, and it's not very surprising considering the public health emergency. But as you can see, it does look like the BME is somehow schizophrenic. It has schizophrenic tendencies of wanting to be egalitarian as well, which is not really surprising either. The first quote says that in dangerous pandemic, the ethical balance of all doctors and healthcare workers must shift towards utilitarian objective of equitable concern for all, while maintaining respect for all as ends in themselves. So this is rather contradictory. So we want utilitarian objective, but we want equality in treatment. The second quote that also is striking says that the focus of healthcare professionals' attention during triage will be on delivering the greatest medical benefit to the greatest number of people. Well, yes, of course, this is all well said and done, but we have very limited resources. So we know that the greatest benefit might be to a few people only. And the guidance does acknowledge the situation of crisis. What's most interesting is the final quote, which says that priority to those those who are responsible for delivering those services and who have a good chance of recovery should be given. So basically, it speaks to the principles of medical utility, saying that we should be giving priority to essential workers and medical professionals. And this speaks volume when read in a correlation with the communication put out by the BMA, because there was clearly no clear guidance from the government on PPE, and also the medical workforce felt very vulnerable. But then it contrasts with some very egalitarian approach. So the guidance here tells us that if we are in a situation that becomes very critical and we have multiple people in ICU, COVID patient or non-COVID patient, we should allocate the resources then equally to them, and we should not be doing a ranking of needs. And then a few lines later, from that quote, for a few lines down, it says that, however, we should operate a queuing system in order to do that, which is not really in line with egalitarian rhetoric, but rather a first come, first served basis. With regards to the Royal Colleges, well, the guidance was published roughly a week after the BMA guidance, and it provides professionals also with some principles for decision-making, bedside decision-making mainly, staff management and PPE. It was supported by the Royal Colleges themselves and multiple stakeholders, and interestingly, the regulator and licensing authority of the medical profession. Here also, it sets a very clear framework for the development of this guidance, and we see that here it is very much geared towards procedural justice. The guidance itself is really not explicit about triage or resource allocation. It's even broader than the BMA guidance, and there might be a reason for that, since the 10 Royal Colleges supporting this guidance were willing to adopt it. They decided to leave it in broad terms in order not to interfere with the different specialties of the different Royal Colleges. So we see that the critical nature of the crisis is noted, and there's really an emphasis on teamwork and solidarity, which we would say could be equated to an egalitarian rhetoric, but it is rather unclear. So in conclusion, I would say that the role of medical professional in COVID-19 healthcare lawmaking or rulemaking, as these are not enforceable law, is somewhat different in the rhetoric that's employed. Of course, there's an egalitarian kind of predominant undertone, but also equality and access to care wants to be preserved, which is in line with the traditional discourse of healthcare professionals and law and policy making. We see that the role of healthcare professional, again, has been kind of more following national guidance. They were reluctant into publishing new guidance, especially with regards to triage and resource allocation. This may be, as I said, because of the difficult position they were put in, but also it may be because of the dialogue or the lack of dialogue that the profession had with the government at that time. We will be exploring the validity of my findings in the subsequent portion of the project when we will be conducting in-person interviews with members of the Royal Colleges and NICE and NHS England. So I will leave it at this for now.
Thank you very much, Sabrina, for a fascinating paper. We have a question from our audience that I want to start with.
Sure.
Do you foresee that the COVID guidance from the BMA will shift back to egalitarianism from utilitarianism the longer that the pandemic continues, given that this may no longer be considered an emergency, but perhaps the new normal?
It's a very good question, and thank you for that question. So that speaks very much to kind of what we could deem that COVID-19 is an unprecedented event, and it calls for the suspension of kind of the egalitarian approach of the NHS. And in the long run, I do believe that we will have to deal with it in a different way. And I do believe that the BMA might have to reissue some guidance. With regards to PPE, I don't think the guidance will change, because the guidance was about protecting healthcare workers, and that PPE should be allocated in proportion to the risk. So that, I think, won't change because the risk will still be there. However, with the management of patient, I think things will be very different, because one, we will most probably manage the disease better, but also we have an extremely big backlog of care right now in the NHS. And now COVID-19 patient may no longer be the emergency patient. We see cancer patient, for example, may be becoming more of a priority for the NHS than COVID-19 patients. So I think we will have to shift and and access to care will be a very big issue in the very close future, at least in 2021, 2022, because going back radically to equal access to healthcare will be practically impossible because we've suspended the care for so long or interrupted it. But I could see certainly a revision of the guidance, yes.
Great. I want to ask about this very fascinating work around the rhetoric of justice. And what strikes me is that we get some very strange bedfellows in the kind of different, the shared rhetorics that may emerge, and particularly around anti-lockdown positions. Clearly, a lot of this is connected to a kind of radical libertarianism, anti-communitarianism, but not entirely. And we've seen people like Dr. Gupta, Professor Gupta from Oxford, who, I mean, I think I'm not sure if this has shifted a bit, but certainly at the outset was very clear that she was speaking not as a libertarian, but as someone who characterized herself as of the left in being skeptical about lockdowns. So I wonder if you've had any thoughts about some of these different ways in which different constituencies are using rhetorics.
Yes, this is very interesting. There's been a lot of written, and I'll be very honest, it's not my area of expertise, but there's a lot of written in Italy in particular about biopolitics, about kind of how the discourse was instrumentalized to get the population to behave in a certain way, and to be kind of tamed, and taming the bodies. And I think there's an echo and Wayne's presentation of how do we handle bodies, how do we handle public health, and which stand on the political spectrum we take. It's not necessarily aligned. So that's a very interesting point that you're making. In general, with regards to the medical profession and specifically the BMA, it is clear when we look at healthcare reforms what their rhetoric is. And of course, not every medical professional is a member of the BMA. So it's very important to note that, because some of them have come very loudly against what the BMA was saying with regards to school, for example, and patient care. So it's interesting to see that the medical professions wants to look like they have a unified voice. One NHS, we're clapping for our carers. We're all on board under this big umbrella of the NHS. But then within the NHS and within the different organization of medical professional, there are different voices indeed.
Okay, thank you. And a question from our audience. What about so-called end-of-life decisions, the tragic choices in terms of shaping healthcare? Mm-hmm. And the questioner refers to in Italy at the beginning of the pandemic, there was a document by the Society of Anesthesiologists to deal with the scarcity of resources in a utilitarian way.
Yes. Yes, so that's what stroked the whole writing of these guidance. So medical professionals saw the situation in Italy and thought, oh, we will be faced with those tragic choices. Both of the guidance that I'm talking about, both guidelines, tell us that this may come to the situation that we will be facing in England. And unfortunately, you will have to make those utilitarian choices. You will have to allocate ventilators in priority. Of course, it's not explicitly stated, but that's what the NICE guidance was saying. The NICE guidance was saying, let's assess patient on a scale of frailty to determine the health outcome that they may get from the treatment. And if they have a higher success of surviving or having an improvement in their health, we will allocate the ICU bed / ventilator to them. And that came under a lot of criticism from disability groups, saying this is ageist and also discriminatory against disabled people, because obviously they will score low. So they had to revise the guidance and say, we will take into consideration, other factors. And of course, this will be taken in accordance with the family wishes, etc. So we won't be allocating healthcare in that way. So the utilitarian approach was not very successful at the very beginning of the pandemic because it was seen as very discriminatory, which it was the case as well in Italy.
Thank you. And I mean, I think in any discussion of kind of the different notions of justice, we would be incomplete without mentioning Sweden in all of this, and which I've find fascinating the way in which the experience of Sweden has been appropriated by libertarians
Yes.
here. Yet, this is, a highly social democratic, egalitarian society. You would never have, prior to the pandemic, expected Sweden to be held up by libertarians as an example to be followed.
Mm-hmm.
So, any thoughts on that?
Yeah, I think there was a strong echo around liberty, around freedom of individuals, and it's a very individualistic perspective on the Swedish policy. I think it's kind of skewed. I think Sweden did well at the beginning, not so well now, but did well at the beginning of the pandemic because of the sense of another very important aspect, which is the aspect of solidarity, which libertarianism focuses more on subsidiarity, which the libertarians seem to want to forget. And that is a massive difference. So if you have a lot of social cohesion and you have solidarity, you can rely on people doing the right thing and trying to preserve their elderly. However, libertarians seem to say, well, I don't really care if grandma is dying. What matters is my freedom, the economic power, and we should all care for our own self individually, which is neoliberal, I would say, rather than libertarian. But so there's a very different kind of take, and part of the problem is that they're forgetting that element of solidarity, I think, in the discourse.
Question from our audience: in light of hopefully coming close to a COVID vaccine, do you foresee new policies regarding the pandemic to come?
Yes, and I think there will be interesting work to be done on that aspect too with regards to resource allocation, because there will be indeed, again, question of solidarity. Do we oblige or do we suggest strongly that people that are healthy should take the vaccine in order to protect our elderly? Do we vaccinate only a portion of the population? How do we allocate the vaccine? Some people will be highly reluctant to take that vaccine because it hasn't gone through the traditional route of all kind of the safety checks. Others will be rushing to take it just to have more freedom. So it will be very interesting to see if people are rushing to take it and there's not enough, or to the contrary, people do not want to take it and we continue having those peaks of infection. So there will be certainly done a lot of work to be done on resource allocation there. Yeah.
Well, thank you very much, Sabrina, for a fascinating paper. We look forward to seeing the final version in the outputs from the series. And in response to a question from our audience, I can confirm that the recording from today, if our speakers consent, will be posted online on our website, and that will include the slides from today, which will be embedded in the presentations. So thank you very much, Sabrina, and we'll move on. And I'd like to introduce our final speaker today, who's Dr. Mark Trabsky. Mark is a senior lecturer at La Trobe Law School, La Trobe University, Australia. His research examines the theoretical, historical, and institutional arrangements of law and death. He's the author of Law and the Dead: Technology, Relations, and Institutions. Mark's paper is entitled Counting the Dead During a Pandemic. Welcome, Mark. Over to you.
Thank you, Carl, and I hope everyone's having a good day. And if anyone is in my time zone, I hope you're having a good evening. I'm speaking from Melbourne, Australia, and just to preface this paper, that I started writing it during what has been identified as one of the longest lockdowns around the world. So we went into our second lockdown in July, and started emerging from it in October, late October. So we're still kind of emerging from it. And as we'll see with this paper, I was fascinated with counting and numbers, particularly around the dead, not so much in terms of cases. What I was interested in is how governments talk about death during a global pandemic, and where this death talk is at the same time incessant, implacable, but also banal. We've seen discourses of death during the COVID-19 pandemic being discussed today. So in the first speaker, images of mass graves and makeshift morgues was disseminated across TV screens around March, April, May, narratives of overflowing funeral homes, corpses lying unattended in hospitals, and as we saw from the second speaker, debates about the rationalization of medical interventions. But I'm interested in a particular kind of discourse, and discourses around the tabulation of mortality rates. And these discourses also sit alongside governmental interventions into everyday life, such as mass testing regimes, lockdowns and curfews, border closures, ring fencing, and other social distancing restrictions, which I believe maximize the efficiency of individuals and the vitality of the population, while also allowing people to die. And as was just kind of discussed before, the rationing of medical resources articulated particularly earlier on in Italy during the first wave, but also more profoundly recently by death panels hastily set up in some USA states, is nothing new for medical institutions. So there's nothing new about this rationing of medical resources, but perhaps during COVID, it has indicated too honestly the extent to which administrative, legal, and medical institutions calculate the social, economic, and ethical costs of Michel Foucault writes, fostering life or disallowing it to the point of death. I believe the COVID pandemic has demonstrated something that Michel Foucault writes towards the end of volume 1 of The History of Sexuality, and that is, to quote him here, "Death is power's limit, the moment that escapes it. The procedures of power have not ceased to turn away from death." So there's many different representations of the COVID-19 pandemic across a variety of mediums from a diverse range of actors, and it demonstrates that there's no one universal discourse. There are fragmented, inconsistent, and often jurisdictionally specific discourses of death circulating around the world. What I'm going to be arguing in this paper is that the deadliness of the virus that causes COVID, the virus that causes complications from COVID, is depicted in the privileging of a COVID-19 toll as exceptional, while on the other hand, deaths caused by the pandemic, but not the virus itself, are normalized as the endpoint of a life cut tragically short or a life lived well. And the adaptation of Nassim Nicholas Taleb's theory of a black swan event very early on around the first wave depicts the pandemic as an aberration, an incongruous disruption in the habitual economy of life and death. Yet this rhetoric of the black swan event, the aberration, conflicts with the pervasive routinization of death, its regulation by a range of administrative, legal, and medical institutions, which gave rise in the 18th and 19th centuries to what Foucault calls thanatopolitics. And in this arrangement of governmentality, the technology of death registration, which consists of the bureaucratic logic of the file, classification systems for death causation, and the tabulation of mortality rates, is deployed as a normalizing technique for defining the limit point between life and death. So I'm interested in exploring this tension that's arisen during the COVID-19 pandemic between discourses of death as a pathological and a normal aspect of life. Classification systems for death causation have expanded significantly since the 19th century due to innovations in epidemiology, pathology, and forensics. And we should note here that epidemiology and public health discourses were born in England in the 19th century. So it was a response to the spread of disease in inner urban slums, and also a response to labouring conditions. And you have in the 19th century the birth of these disciplines. During the COVID-19 pandemic, the epistemology of the cause of a death has been revealed as somewhat contingent. And there's a shout out to the UK here, because particularly in the UK, COVID-19 is being variously classified as causative of death according to the place where a person died. So early on, in the year, I believe that the UK government were not counting deaths that occurred at home or in nursing homes or aged care homes, but that I think has changed now. It's also contingent depending on the symptoms prior to one's death, or whether a laboratory test was undertaken while they were alive. And we should note that many different places around the world, especially in developing countries, do not have the capabilities of testing huge amounts of the population, and there are most likely people who are dying from or with COVID, but without a test being undertaken. The technology of registering a death in the time of a pandemic depends on differentiating between the normal and the pathological, standards and variations, and averages and excess. And so what I argue is that what the pandemic has revealed is how the technology of registration normalizes death as both an abnormality, but also an inevitability of life. It's inextricable from how a range of institutions determine what deaths should be counted at all. In the normal and the pathological, George's Calgian offers a history of the relationships between the concepts of the normal and pathological in the disciplines of biology, medicine, and nosology. And he refers to a whole swath of writings of French medical and scholars, quoting that pathology manifests as a quantitative variation of a normal state of existence, while, quote, the scientific study of pathological cases becomes an indispensable phase in the overall search for the laws of the normal state. So he reiterates throughout the book this kind of constitutive relationship between the normal and the pathological, and how it's shaped by quantitative, statistical, and mathematical concepts. So the normal is the average, and the pathological can only make sense as a quantifiable deviation from a norm. When he applies this theory to the science of biology, it becomes clear to Calgian that life is the normative state of the human body, and death is nothing other than an inclined variation from the functional order of things. So what he sees in these writings is that death is not a kind of abnormality in itself, but rather becomes pathological due to its divergence in degree from the standardization of life. Here, life only becomes a norm given the habitual regularity of the functioning of the human body, and it remains in this fragile state until the body is disrupted by disease, illness, or death. And I'm happy for people to ask some questions about whether they feel that is the case for medical practitioners today, that they see death as just a kind of deviation in degree from a standard. Media coverage throughout this pandemic has questioned this idea of, is there a true death toll? How do we know it? How many people have actually been killed? Are there more? Are there less? Have we overstated it? Have we understated it? And in all these different questioning around death talk, whether it's initiated by governments, articulated by epidemiologists, or reported in the media coverage, there has been this kind of separation between fatalities or representation of fatalities directly caused by the virus, and they're seen as abnormalities of the life course, whereas deaths directly, indirectly, or even tangentially related to the pandemic, for example, deaths due to suicides, accidents, violence, negligence, chronic illness, or other diseases, are represented as the inevitable resolution of a life lived well, or a regular, a bit tragic end of a life cut short. The question of how death can appear as both normal and pathological can be answered by examining the institutional practices that underpin the technology of death registration. And there's two that I want to just briefly note here. So classification systems for death causation and the tabulation of death rates. So the first practice derives from how a cause of death is identified by legal medical institutions for the purposes of compiling mortality statistics. There are legal procedures for completing a cause of death certificate or form, and they attribute responsibility to medical practitioners and empowers them to use medical knowledge to differentiate between underlying, associated, and multiple causes of death. And the second practice, the tabulation of death rates, is inextricably dependent on this first one. So what is included or excluded in any given death toll in any country relies upon an administrative decision, which I would describe as thanatopolitical, to either only count deaths where the SARS-CoV-2 virus is identified as the underlying cause, or also count deaths that have a different underlying cause, but where the virus contributed to the death. It's very confusing across the world. Even in the US, there's different states doing different things. The CDC is constantly trying to unify it. In Australia, we had a similar problem with a difference between the federal counting of the death toll versus the state's counting of the death toll, and also complications between what aged care providers or nursing home providers saw as what counted as a COVID death versus what the government saw should be collected. So the complexities of this classificatory process should not be underestimated. It's contingent upon medical practitioners distinguishing between dying from the virus, where it's a direct cause, as opposed to dying with the virus, where it contributes to the death. And epidemiologists often express this in terms of degrees and percentages. So they start to quantify this. It's a 10% contribution, a 50%, a 70%. And to determine whether a person has either died from or with COVID, medical practitioners must first ascertain measurable characteristics of each death. So what is the age and sex of the deceased, the location and time of death? Are there any pre-existing comorbidities? Whether the person tested positive for the virus prior to the death? And then compare those characteristics against broader mortality trends. So they must contrast the individual death against a typical death for a specific segment of the population. And this is gleaned from both their own experience and training and knowledge, but also their interpretation of universal nomenclature for the classification of diseases and illnesses, which is constantly a work in progress and is updating precisely during the pandemic about what is a COVID death. So the counting of COVID deaths, what I'm suggesting here is that it's contingent upon classification systems for death causation and the tabulation of mortality rates. While the death that occurs during a pandemic may not be counted in death tolls for a variety of reasons, so whether the virus is classified as associated, not underlying cause, or a lab test wasn't taken, or not the right lab test was taken while they were alive, or the person's symptoms prior to death did not meet clinical or epidemiological criteria. What I'm most interested by is about how the process of counting a death, so registering a death, normalizes that death as both an abnormality, but also an inevitability of life. And this is most apparent when considering how the privileging of a COVID-19 toll, so a creation of a new table for measuring the rate of death in a population, represents deaths directly caused by the virus as exceptional, while it depicts other deaths caused by the pandemic, but not the virus itself as normal, and thus not included in the official toll. Yet, and this is where the paradox really manifests, a normal death during the pandemic only makes sense if it corresponds to an average, which is ascertained by examining mortality trends over a specific period of time. So if a death exceeds that average, or to put it another way, when the amount of death in any given period deviates from standard rates over the same period of time, then the normal becomes pathological. So that takes me to the epidemiological concept of excess mortality, and this will be the kind of final part of this paper. And excess mortality has been the subject of much fascination since the beginning of the COVID-19 pandemic. I'm sure there are a lot of people who have seen that term excess mortality around the place in newspapers, epidemiologists talking about it. The term denotes the assumption that a population has a normal death rate. That's a fact. that's presumed. Epidemiologists say there is a normal death rate, which also presumes that death is normal to begin with. This is another kind of matter of fact in this discourse. Death is inevitable, it's necessary, and perhaps even for a politics of death, it's a desirable outcome of life. And that's getting back to, what happens if none of us could die? How would government survive? During the pandemic, excess mortality has been used to describe official statistics as inadequate and suggests that more people are dying from or with COVID than has been counted in government tolls. A lot of libertarianists have been using it as well, or various groups to both say that governments are overstating the death toll or understating. So it's been used in different ways. So, for instance, it's been used to contend that the governmental response to the pandemic has caused a disproportionate amount of death that is not counted in any tolls, such as deaths from missing urgent medical care or necessary health checks, reductions in screening, diagnosing and treating a range of diseases, illnesses and conditions, and spatial barriers to accessing time-sensitive medical treatment. So during the long lockdown that we've had in Melbourne, there's been a significant drop in screening, diagnosing and treating for cancers. Notable, but all that's been said is, well, this could produce at some point in time an excess mortality. And this is in addition to claims that there will be an increase in deaths. In Victoria, the predictions of 25% increase of deaths caused by suicide over the next year or two, accidents, violence, negligence. Epidemiologists, journalists and researchers seem to be all agreeing that excess mortality is, quote, a better way of measuring the true impact of the pandemic. But I want to return to Carl William here, because if mortality can be described as excessive, and he notes this with regards to life tables, it's only insofar as the amount of death deviates from an average. And he shows that the measurement of excess death is made possible by its comparison to a numerical average, which he also says is the articulation of a qualitative judgment about the value of human life. Not all deaths are equal is the answer to the question posed by journalists about whether it's possible to ascertain the true death toll of COVID. The point here is not that the mathematics of counting death is true or false, but rather that what counts in the toll depends on technologies that normalize death as both exceptional and typical. So what the term excess mortality shows then is that governments make decisions about how to count a death during a pandemic, and that depends as much on the tabulation of death rates, so the technology itself, as on the making of normative judgments about what deaths are worth counting at all. The technology of registration makes use of classification systems for death causation and tabulation of death rates to normalise death as both this unruly aberration and inevitable outcome of a life. For the living, compiling mortality statistics and measuring death against an average helps them make sense of the exceptional as a normal endpoint of a life. So what I've suggested here, quite briefly, is that during pandemics, governments harness these technologies of registration to define the limit point between life and death and determine what death should be counted in daily tolls. And when I mean the daily toll, literally it was in Melbourne, every morning we would wake up and we would hear the number of people who would die overnight from or with COVID-19. Now, it may be concluded that this argument I'm making is nothing new and that all it exposes is how a technical and scientific process that is unremarkable at the best of times only becomes more perceptible during a cataclysmic event. But perhaps it does more than this by reminding us of how the transformation from sovereign power to biopower in the 18th and 19th centuries did not only generate technologies that seek to incite, control, optimize, and invest life. Governmentality, as a technology of power that optimizes life, has never shied away from making calculations of death. In other words, maybe we've forgotten that while the exercise of biopower fosters life, it also visibly lets people die, whether at the hands of the state or through the absence of care. So thank you for that.
Thank you very much. Thank you very much, Mark. That was a fascinating paper, and I think drawing on Foucault is a really productive way to analyze these issues. Just to start the discussion, one thing that was striking in the UK at a certain point during the pandemic was one day it was announced that there'd been overcounting suddenly, that because they hadn't been using a 28-day cutoff around kind of diagnosis with COVID and death, and that the numbers therefore were revised downward of death, which I think really highlights this binary between the pathological and the routinization, and how constructed it is, that suddenly some of those deaths had to be moved from one category to the other overnight.
Look, definitely, because to do a comparison with Australia, that there hasn't been, and there won't be, I don't think, at any point, that cutoff. So there hasn't been that imposition of a cutoff in terms of 28 days. But there was tension there between different aspects of government in Australia about precisely that. So we had a Victorian government in the city of Melbourne that didn't have that cutoff, that was including everything, and was communicating those daily death tolls every day, when they were also reiterating governmental interventions into everyday life. So I am making the point here is that lockdowns and death tolls are very much connected. I mean, I fathom people who don't see that way. I mean, the government was clearly saying lockdowns and death tolls have nothing to do with one another, but I can't see how that's the case when they're mobilizing it. So I think that what you're talking about in England, there was also a day where they massively increased the number of deaths because they weren't reporting deaths from nursing care homes. I think one day it went up by maybe it was like 10,000, and then now it's gone down. I do think that we're seeing administrative decision making around what deaths should be counted, and the morphing of epidemiological knowledge, which is not apolitical. So,
indeed. And the other thing that strikes me in this binary of the aberration and routinization is ritual, and the ritual of the daily press conference that we had for what felt like weeks and weeks and weeks in the UK, the daily Downing Street press conference, which was like this ritual of the revealing of statistics and the explanation of them, which I think has been true around the world, that there needs to be this kind of ritual of death, which is statistical information.
Yeah, definitely. Like we're used to a lot of tolls being communicated to us, but not in the way of a daily press conference. So, I mean, we will be aware of road death tolls, I should say, particularly popular in Australia, but at the end of the year, we might find out what the road death toll is. Suicide death tolls is another one. Tolls around deaths from intimate partner violence is another one. The really curious one, it's a really great comparison, is the flu death toll. And what happened to the flu death toll this year? Because of the lockdowns, we have seen across the world significant, in most places that have gone into lockdown, I should say, significant decreases in the number of deaths due to the flu. At one point, I did see someone asking a politician during a press conference, so next year, are you going to be doing daily press briefings about the daily flu death toll? And or will you be going into lockdown to prevent flu deaths? And the person kind of chuckled a bit, like, of course not. So it does raise this idea that dying from the flu is a normal. It might be tragic, especially if someone's younger, that it's seen as a tragic death, but it's a normal part of life to die from the flu each year. But the COVID the COVID death is rendered pathological precisely through that ritual of the daily press conference.
The other thing that has struck me around the world is a kind of weird, I find, democratization of statistics and around death. Everyone can be an amateur epidemiologist, it seems, being able to interpret what this means, what excess death means. There is this kind of democratization around statistics that seems to be going on.
Yeah, I mean, part of my research interest is in deaf literacy, and I'm interested in how people are talking about death. I'm not sure whether the democratization of death statistics has seen increases in deaf literacy. I think that's yet to be studied as to what are the effects of the armchair epidemiologist kind of endeavor. Does that mean that we are becoming more aware of our own mortality and the mortality of our loved ones, or is it, or are we seeing them? I would say that part of the art of rendering deaths as mortality rates is distinguishing the death from the individual, and so depersonalizing that death and making that death count as a number in a set of numbers. There's nothing controversial about this. It's been going on for hundreds of years. We have the census, we have the death registration process, we have statistics. So the question I have is, if we're all suddenly fascinated by this, but we weren't previously, are we depersonalizing death? Do we see the deaths occurring as individual people with biographies, with loved ones, or are they just numbers? And are those numbers creating fear in our mind? Are they giving us control of how to make sense of this, impossible experience of death?
Question from the audience. It's interesting to think about the way in which norms in relation to counting have been constructed within the pandemic itself. For example, the way in which we now compare figures on daily deaths to the first wave and use those months as the standard against which to assess second wave deaths. Maybe that's to be expected and unremarkable, but I wonder what it does to how we think about it all. As to me, it seems to have some effect. I think fascinating question.
Yeah, and look, let me preface this by saying that I'm not an expert in what's happening in Europe and UK, but I can give the perspective of someone who is sitting in Australia and seeing these kind of articles come out. I think that the comparisons are being made throughout the media between the first wave and this second wave, and the rhetoric that's coming out is about increases, and lockdown. So I don't think it's coincidental that these comparisons are being made to justify going to lockdown when a number of political leaders said they would not. So thinking about Macron in France, but also Johnson in the UK, they were staunchly saying we would not go to lockdown, we will not go to lockdown. I think that comparison is being mobilized to justify those governmental interventions. Even in Sweden, I believe it's a similar thing. And I should preface also that, or I should caveat here, it's not just the counting of death, it's also the counting of hospital admissions. So recently in Sweden, I think they said they're really alarmed by the increase in hospital admissions. It's more than the first wave, and therefore they need to do X.
Great. Well, I think on that note, I It's time to draw today to a close, so thank you very much, Mark. Finally, I would like to thank our three speakers for joining us today and presenting such incredibly rich and deeply textured papers. Thank you as well to our audience for joining us and for your participation. Our next workshop in the series will be on the 8th of December at noon GMT, and I hope you will join me then. Until then, it's goodbye from the Institute of Advanced Legal Studies. Goodbye.